Okay, good afternoon, ladies and gentlemen, and welcome to Staffordshire County Council Oak Room for the Staffordshire Health and Wellbeing Board this afternoon. You're all welcome. Right, so we'll crack on with the agenda. Item number 1, we start with apologies.
Thank you, Chair. Apologies have been received from Bernie Brown, Jill Heasom, Rita Hesseltine, Tim Clegg and Emily Clark.
Okay, thank you. Does anyone else want to offer anybody else's apologies while we're here? No? Okay. Any declarations of interest? No? Okay, so you should have all received a copy of the minutes of the last meeting. Are there any matters of accuracy or any matters arising? And if there isn't, I'll take those as read. Okay, there's nothing there. Okay, thank you very much. Do we have any questions from the public?
No questions received.
Okay, thank you very much. And then the item E on the first item is Health and Welfare Strategy, the quarterly data. That's available for anyone to look at the link that's in the paperwork. Okay, so we'll move swiftly on to item 2 then, which is the Good Mental Health Priority Progress Update. And I think I'm right in saying, Karen and Nicola, is that you to present? Okay. Thank you very much.
Okay. I'm not sure if I've just turned my microphone on or off.
It's on.
Is it on? Yeah, good. Right, so you've actually got about 4 officers here, and the reason for that is good mental health is such a massive priority area that you couldn't even really just have myself, and I'm Karen Coker, the lead commissioner for children and families at the County Council, and we've got Nikki Bromwich from the ICB. We wouldn't be able to really do this item with just the 2 of us, so you have got a range of colleagues here which will either be talking through some of the slides or here to answer some of the questions that you might have following the presentation. And on a related note, it is such a massive area, and if you've seen the slides, you will see they are many and lengthy, and we did our best to shorten them, but it's such a massive area that it's incredibly difficult, and I think even what we've included on the slides, to be quite frank, is just scratching the surface of what's going on across Staffordshire around good mental health. So, there we go. So taken from the Health and Wellbeing Board strategy, for good mental health, it's around building strong and resilient communities and individuals who are in control of their own mental well-being. And we've got 11 points there, which I'm not going to read out, but there's 11 points there that sit under that we want to encourage. An example being more social interaction and more physical activity because of the link that has to mental health. So we've tried to organise these slides and this update around each of those 11 bullet points, which is why there's quite a few slides. And even so, as I said, we've only really just scratched the surface of what partners are doing in this particular priority area. So in terms of more social interaction and more physical activity, we've included a bit of information on this slide around the commissioned family weight management service. That's something that we commission as a county council. We've put some outcome data around that service in that box to the right of the slide. So you can see for that particular contract year, 96% of all children and young people who access that service maintained or reduced their BMI on exit of the service. 95% of children and young people using the service reported achieving their goals around physical activity, which obviously links to the physical activity part of this bullet point. And 50% of children and young people measured 6 months after exiting the service continue to maintain or reduce their BMI. So that's some outcome data around one specific service. We've also included on there, and it seems like such a small part of the slide, around Better Health Staffordshire, which is the whole system approach to healthy weights and all-age approach to healthy weights in Staffordshire. So we've put some information around Better Health Staffordshire on the slide because it very much links to this point around good mental health. But we haven't gone into enormous detail because Better Health Staffordshire links to the healthy weight priority, and I know the board already had an update on that back in June of this year. So we haven't gone into masses of details around that, but just wanted to show the link. So in terms of reducing unsafe social media use, We have a prevention working group for children and young people's mental health. And one of the many things that prevention working group is trying to do is to work in partnership to address harmful social media activity, but to also harness the benefits of social media to support emotional well-being. So some of the examples are the family hubs in Staffordshire have worked with partners to produce a Keeping Safe Online webpage for parents and professionals, and the link is there in the slide for people to access. We have embedded across the mental health pathway for children and young people the Tell Me Wellbeing peer support app. We piloted that for a couple of years ago, and got some really positive outcomes from that. So that's now embedded within the children and young people's mental health pathway. So that's an example of where that kind of digital app is actually proving to be very beneficial in supporting good mental health. And then we've got the WAM plan, which is another peer support activity for children and young people, and they aim to co-produce, so this hasn't happened yet, but they aim to co-produce a module around social media use before April 25. And in the box on the left there, we've just given some examples of how we've also touched upon reducing unsafe social media use and the dangers of it and so on in the Kind Minds newsletter, which gets distributed to education establishments across Staffordshire, but also many other partners as well. That goes out every term. And it says there, just to give you an idea, that the Kind Minds newsletter reaches around 6,000 teachers in Staffordshire and over 400 Staffordshire schools. And it's really well received, actually. So we're using that for lots of the things around good mental health. 5 ways to wellbeing and other evidence-based approaches. So this slide particularly concentrates on 5 ways to wellbeing, which I know the public health team are leading on. So it's now core to the County Council's website advice on mental health and wellbeing, and it has its own webpage for people to access. So again, you can find the link in the slides. 5 ways to wellbeing messages have been, used, have been used as part of the Let's Talk About Shobnall community work, which was aimed at reducing suicides at a high incident location. And recently there's been a wider partnership event exploring how we can develop a whole system approach to raising awareness and making the concept more accessible and practical to the public in terms of the 5 ways to wellbeing. And again, in that little box on the right there, we've just given an example of how we've covered things around 5 ways to wellbeing in the Kind Minds newsletter for our education partners in particular. And I think, Nikki, the next slide is one for you.
Excuse me. So in terms of perinatal mental health, the ICB has had a programme in place for just over 2 years now in terms of an expansion around improving our offer. We have significantly invested this year across both Stoke-on-Trent and Staffordshire as well to improve that offer, and that's very much in line with meeting our responsibilities under the NHS long-term plan. So fundamentally really reducing that waiting time for treatment, making sure that we have parents on the caseload for a much longer period of time, so over 2 years. Very much focused on actually how do we care for people within the community, so trying to reduce that inpatient admissions as well, and really improving our psychological therapy offer that's available to make sure those interventions are evidence-based and making the difference, and extending obviously assessments to partners of the mothers as well. So lots of work that's going on in that area, and as I said, that investment's only just been released sort of August time, so we haven't realised some of that opportunity yet, but that will start to embed itself as we move forward into the next year.
Okay, so in terms of early identification of mental health issues in children and young people, there's lots of different things that we're doing across the Staffordshire system, if you like. The County Council, the ICB and a number of other partners work together on arranging termly virtual meetings for mental health leads in education. So every school is supposed to have a named mental health lead. So the termly meetings they started in COVID actually, so they were half termly, moved to termly. We share good practice between the schools as well. There's peer support, It's encouraging better communication between education settings and mental health providers about the support available, the resources. It's an opportunity to ask questions. And as an example, in the autumn term of this year, there were 263 Staffordshire members. So that basically means 263 mental health leads from Staffordshire schools, which I think is a really good achievement in terms of attendance, and it has increased over the years because we have, about 400 odd schools? I'm not sure of the exact figure. So 263 attendees is good, but we obviously continue to try and grow that to make sure that mental health leads in every Staffordshire school have got access to that and are working together and sharing good practice and hearing from mental health professionals within Staffordshire to get them more knowledgeable about what's going on, more confidence in how to support children and young people. Because not every children and young person needs a service, and so it's trying to upskill those professionals that you don't have to be a mental health professional to provide support to children and young people around good mental health. We have a prevention working group, which I think I mentioned earlier, around mental health. They've got a number of task and finish groups, so they've got one around early years in terms of mental health, suicide postvention, one plan which is around peer support, and fairly recently, over the last few months, we've had 3 professional development days involving mental health professionals within Staffordshire and Stoke, and children's social care colleagues in particular. We had 166 attendees. We've had really positive feedback from those first lot of development days, and a full evaluation report is in the process of being produced around, the impact of that really. So we'll have something more concrete to share at a future meeting around what was achieved and what we're going to do next. And we've also updated an interactive map of children and young people's mental health support, which is available upon Staffordshire Connects. That was in need of a refresh, and that's been done this year as well. And again, we've had really positive feedback from professionals, whether it be GPs, colleagues within schools, that it's really helping them to simplify what is a really complex system of support around mental health. And again, just on the left there, in terms of the Kind Minds newsletter, I mentioned how many schools it goes to, but you'll see there it says that last financial year, there were 1,168 direct subscribers to the newsletter. So not just going out to every school, but other partners as well, and alternative education providers, colleges, universities. We've had other partners who've asked to be on the distribution list for the Kind Minds newsletter because they value the information within it. We commission, jointly with the ICB, we commission a Children and Young People's Emotional Health and Wellbeing service, currently provided by Action for Children. It's in its final year of the contract, which ends at the end of March next year. So we have just gone out to tender for a new service, again with the ICB, and the new contract is looking to be awarded in January. It's taken learning from the last 5 years of the existing service around what's worked, and lots of things have worked from that service, but also looked to what improvements can be made as well, and taking into account work that's been done, particularly around care experienced children and young people, and what they may be missing from services around mental health. And this service is not the only service there for care experienced children and young people in mental health, but it's one of the services that could support them. And some of the additional things that have been built into this service moving forward from April includes a consultation support by the provider to the network of support around children and young people. And it's children and young people who are care experienced, children in need, children on child protection plans, and broader, so the more vulnerable children and young people, so who might not be ready for direct therapeutic support at that point, but the support to the care network around that child or young person will be really beneficial. And also clear prioritisation of vulnerable cohorts, so the same cohorts that I've just mentioned, but also children and young people with SEND, the kids that are persistently absent from school, children and young people who've got parents with poor mental health, young offenders and so on. They're more vulnerable, and therefore they'll be given prioritisation in terms of accessing that new service from April. And we're taking a trauma-informed and attachment-aware approach to that service. And again, in the box on the right, you can see some of the outcomes that have been achieved last financial year. So 100% of the vulnerable children and young people who are accessing the service achieve their outcomes, which is obviously a particularly good outcome. Oh, I think this is Nikki. I think this is over to you, this slide.
So as part of our NHS offer really around mental health and wellbeing in conjunction with the offer Karen's already discussed is really around our role in mental health support teams in schools. So members of the board will be aware we've had an expansion programme very much around that in terms of trying to get as much coverage as we can for all of the schools, and obviously there are quite a large number across Staffordshire in particular due to the very rural nature of some of the patches, and that's very much about delivering that whole school approach and also offering that dedicated support within the school setting. So getting lots of positive feedback from families, from teachers and from the children themselves in terms of what a difference that's made to them. And there's lots of feedback, so unfortunately again in the interest of slides we haven't been able to include all of that, but again we are continuing on that expansion programme, so we are very fortunate to be able to say we have a mental health support team, at least one in every district and borough across the council, and we have a new team commencing in January which will cover the sort of the Newcastle and Lyme Moorlands patch, and obviously we're awaiting our sort of new guidance to see how we can further expand that. We also have our Children and Young People's Mental Health Local Transformation Plan that is very much led by the ICB but is absolutely co-produced with partners and certainly with our local authority partners and providers. So that's really setting out our sort of work programme for the next sort of 12 months, and we have that as an iterative process to go back to what have we achieved and the differences that we need to make. In terms of where we are in terms of our CAMS provision, again we have released additional investment that is more focused around the crisis response at the present in terms of Staffordshire to provide that sort of levelling up. But at the moment, we've got quite a big programme of work around looking at our specifications, understanding what our CYP mental health access is, and Nikki Smith is leading that work for me and my team to really get underneath that and start to look at actually how can we change the system so that we're delivering the earliest care possible to children and young people, and now obviously providing that specialist response within CAMS where it's needed to make sure we get that flow through.
So stronger focus on workplace mental health. So at the County Council we have the corporate Wellbeing strategy. Includes mental health first aid training. We have a lot of mental health first aiders trained at the County Council. Wellbeing webinars, the Think Well service, which is a counselling service and other resources. The public health team have commissioned 10 live wellbeing webinars over the last 12 months, and they continue to develop resources to promote those webinars. And a specification is developed to launch a procurement of a package of mental health and wellbeing training, including both mental health first aider training and more general resilience training to small and medium enterprises in Staffordshire in 2025. So in terms of reducing suicide and self-harm, I suppose the main point to note really on this slide is that bit in bold there to the right, which is that suicide rates have been dropping in Staffordshire since 2018 to 19. The rate in Staffordshire is no longer significantly higher than the national average. And on the right there, it provides some bullet points of some of the activities that have been happening in relation to that and that have obviously contributed towards reducing the suicide rate, such as a programme of activity including community suicide awareness prevention training. And I know that's been advertised and promoted very broadly, so lots of partners and lots of colleagues have been on that training. Physical improvements at sites of high public suicidal activity. So lots of different activities that clearly must be having an impact because we are seeing a drop in the suicide rates within Staffordshire. And then in terms of tackling loneliness and social isolation, the public health team at the County Council have got the Supportive Communities programme. So we've got a number of community help points, digital resources for information, advice and guidance, such as the Staffordshire Connects website, Efforts to reduce loneliness and social isolation are also being made by a volunteer Buddhist scheme, and we've got some additional information on the next slide that sort of links to this as well. So the family hubs in Staffordshire, they have a volunteering programme, so there are currently 64 active volunteers across the county through the family hubs. Obviously that's there for lots of different reasons, but it's helping people to learn. So again, it links back to the 5 ways for wellbeing, developing new and existing skills, gaining confidence, helping with their wellbeing, getting that connection to the community and other people. And there's a very small, so you won't be able to see it on the screen, I'm afraid, but there's a very small sort of case study or example on the right-hand side there from somebody who is a volunteer with the family hubs and their particular thoughts on being a volunteer and the impact it's had on them. And then likewise, we've got the Open Door Staffordshire work experience programme. And again, there's a case study there, which is written a bit bigger, so you'll be able to see that hopefully. There's a case study there from James, who joined Amy to work as a scheduler on the council's highway contract 5 years ago, joined through the Open Door programme after suffering with his mental health, going to prison, attempting to take his own life. He said that Open Door saved his life and allowed him to progress in his career. So he's a real advocate for mental health. So, encouraging and enabling communities to support each other. We've talked about the One Plan before on previous slides because there's a lot of cross-cutting things on here. So the One Plan is the peer support for young people in terms of providing support to each other around emotional well-being. The Tell Me Wellbeing Support app we've talked about, which is an actual app where young people can provide support to each other. It's an NHS approved app. Any comments that are released on that app get checked before they are released, so it is a safe app. And the Prevention Working Group, which again we've mentioned previously. On the right hand side in the box there, it just again gives a few sort of outcomes, if you like, around the One Plan particularly. So 64% of participants reported a positive change in their mental well-being from being involved in the One Plan, and 100% of the respondents indicated that they would be confident to deliver and share the One Plan with their peers because it is a peer support programme. I promise we're almost there. Encouraging and enabling communities to support each other and themselves. So this is some of the figures, if you like, some of the impact from the Supportive Communities programme, which sits with public health. Probably the two main ones I think to mention there are, there's been 755 volunteering placements brokered through that programme. We've got 52 people who've been helped to get home from hospital sooner, but there's lots of other stats on that, as you can see, in terms of some of the things that have been achieved through the Supportive Communities programme from 2020 to March 24. And then I think I'm passing over to Jan for the next 3 slides.
I think me and Nikki are going to do them together. Thank you, Karen. So, Good Mental Health in Staffordshire strategy was approved in March 23, just to remind the board. It was approved in March 23, and then the Supporting Action Plan was approved in September 23. So we've just had just over a year of delivering that. That's joint with the ICB, and although the focus is on adults, we've also worked with children and families to look at particular areas that can support young adults through into adulthoods, and it's also public health and prevention inclusive. So on the slide there, you've got the 6 priorities. The first one is really focused around the public health areas and preventative services and early intervention. The second priority focused around access, transformation of services and sort of workforce priorities to make sure people have access to services when they need it. The third priority around crises is focused around NHS crisis services and around suicide prevention. The fourth priority is really around equity, so around equalities and actions around co-production and people with lived experience involved in the support they receive, and also parity with physical health around areas such as physical health checks. The fifth priority is around people with severe mental health problems supported to live in the community, and that includes actions around things like employment, community services, adult social care, people with care and support needs and models of care, so around residential and nursing care, supported living and housing with care as examples. And the final one is there was a couple of actions we'd included early on around where we could work with children and families to support young adults ahead of them transition to adulthood. Just go on to the next one. I think, Nikki, you're going to cover these are the ICB ones.
Yeah, so in terms of crisis provision, what we have been working hard again across the whole of our patch is around implementing a number of schemes. So NHS 111 option 2 is what we call it. So that has, it's been available across the patch since April, but is kind of formally launched in September in terms of people being aware of how to access that. So that is essentially where it's about bringing parity of esteem for physical health and mental health, so that if somebody calls 111, they can opt into that mental health response. So it will link them into the 24/7 all-age urgent access lines that we have commissioned and are in place across the patch as well. So that will enable our providers who have access to the patient's electronic records to make sure that we get that swift response in there. We also have been doing a lot of work with our ambulance provision, so WOMAS, and we have a mental health specialist response vehicle in place that has been operating now for quite some time, and we're getting quite good outcomes in terms of how that's being used. It's still relatively new, so we're just in the process of doing an evaluation. That's something that we commissioned on a regional footprint with our other ICBs, and as part of that we also have dedicated mental health clinicians as part of the control unit within WOMAS as well. So again, making sure that that expert advice is there to ensure that an ambulance is only called when appropriate for somebody with a mental illness, and actually we can skill up our paramedics to have a different response that actually means that mental health services are meeting those needs rather than having a disposition to A&E. So we've got a number of aspects in place. We've also got, as I said, looking at children and young people's crisis response in terms of how we do that. We're working a lot in partnership with our police colleagues around right care, right person. And I would think kind of phase 1 and phase 2 have been fairly successfully implemented, and obviously we're in the process of reviewing sort of phase 3 and 4, and obviously that's a lot around the section 136 activity and how we make sure that we're getting the right experience, and part of that is going to be the ICB with our provider partners reviewing the community triage offer that's available to the police as well. In terms of inpatient provision, so in July, I think the months just fly by, don't they? So I think it was July that we went to our ICB board to sign off our adult mental health inpatient quality transformation strategy across the area. And we have, that's a 3-year plan that we'll be delivering on, which is very much a lot of work around how do we prevent admission in the first place, but how do we, once somebody's admitted, ensure that that's a purposeful admission and the best care that we can provide, and then how do we enable timely discharge. But it has a lot of interdependencies with the work that we're doing with our system partners around section 117 and, you know, preventing people being detained in the first place in terms of a mental illness. And we're just doing some engagement work at the moment that we're ramping up over January and February to ensure that we're talking with all of our partners and, importantly, our service users and carers, our residents that will be accessing that provision or may need to access that provision in the future to make sure it's fit for purpose. And we're awaiting the children and young people's inpatient provision, which is being led by our provider collaboratives to come in place, but we'll align that once we've had those conversations. In terms of physical health, again, there's a bit of detail there, so I won't go through it. But again, we're working closely with our public health colleagues in terms of that wider offer within communities and how we can ensure people with severe mental illness are able to access all of those opportunities in the same way that everybody else is able to. One of the key developments there has been the introduction of the mental health ARS roles, the additional reimbursement roles or mental health practitioners that are in most of the PCNs, primary care networks and GP surgeries now, and they're really supporting that intervention. Unfortunately, there still is that huge mortality gap between people with a severe mental illness, so it still is at that 20-year people dying too young, and we still need to do something about that. So it's more than just the physical health checks themselves, it's then the interventions and everything else that we can deliver alongside that. So that's still work that is ongoing and will continue to be ongoing for some time. Thank you.
So just to continue on the last few examples from progress from the action plan. So we've developed a housing with care strategy with district and borough councils. In terms of the good mental health plan, this is kind of emerged through the engagement. Housing was quite a major area highlighted by a range of partners and people with lived experience. Number of problems, affordability of placements, housing placements they had, being able to get and maintain tenancies. So we've worked with colleagues who are leading on the housing with care strategy to ensure that the mental health aspects of the good mental health strategy action plan are incorporated into there, so mental health will be a feature as the housing with care strategy gets approved through governance, which I think is this month, and then there will be delivery plans to support the housing with care strategy and the sort of actions coming out of the engagement for good mental health will be incorporated within that. One of the priorities is around kind of sort of step down to having less people in things like nursing and residential care, more people living in the community in something like supported living or shared lives. This is a really good model of care for people. It has good outcomes. It's similar to adult foster care. So it's where people can go and live with a shared lives carer in a home setting. And we recognise that people with severe mental illness are underrepresented in this model of care. So this is a new action within the plan. So we've been doing some targeted work with the provider of our Shared Lives Commission service and colleagues in MPFT who are commissioned to deliver the adult social care case management function, doing further training, doing myth busting with shared lives carers, offering more training to them to understand the needs of people with severe mental illness. And we've already starting to see increased numbers of placements, social workers sourcing placements with shared lives carers for people who either will be prevented to go into a more restrictive setting such as hospital or being able to come out of a more restrictive setting. In particular, I've seen recently several examples where they're quite relatively young people, and it's nice to see them not going into something more of a traditional setting and being able to be moved into more of a home environment. One of the areas as well we recognised we need to improve on is the co-production involving people with lived experience. When we did the strategy and action plan, COVID was still kind of part of that experience for people. In-person stuff was more difficult. We also, the ICB and NHS partners had done a big period of engagement around the community mental health transformation. So we hadn't done quite so much of that from my perspective, but we're now sort of looking for next year how we kind of do further engagement, really thinking ahead of possibly to the next strategy. So we build up some really good relationships with people with lived experience and also linking in with the ICB and NHS colleagues around the inpatient transformation engagement, which is starting to happen. One of the key feedbacks from the engagement was that people wish the NHS and the local authority worked better together. So again, we're going to continue to do that through that co-production work. And then finally, we established baseline data metrics. So as part of we're going to monitor delivery of the actions, but also look at some indicative metrics. So we've established baselines from the end of 23-24, and then that will be something we'll kind of build a dashboard around to allow us to track that over the 5 years.
Okay. And that is, you'll probably be happy to know, because I know we've been talking for quite a long time, that is the end of our sort of update around good mental health. We want you to note the range of work that's been undertaken across Staffordshire, aligned to the good mental health priority. As I said earlier, there's lots of things going on, which is why there were quite a lot of slides, but I don't even think they scratch the surface of some of the stuff that's going on, really. And because of that, we're asking the board to consider that the next time we provide an update on good mental health, we perhaps do it differently, and maybe pick some of those 11 bullet points that were on one of the first slides around the things that we're trying to achieve, whether we focus on a couple of those at a time so we can provide a bit more detail. Obviously, we need to provide more information on outcomes wherever possible, but it was really difficult today to try and capture everything in, well, it wasn't 25 minutes because I think we've gone over by 5 minutes. So that's our ask of the board, really, that we perhaps do it in a slightly different way moving forward so we can get into more of the detail. But it's over to questions now, really.
Thank you. Thank you, all of that. Before we go to questions, I wondered, and I'm sorry to put you on the spot, Lisa, but I just wondered whether on some of the points that were raised about right care, right person, whether you'd got any comments you'd want to make at all.
So, yeah, I can provide a very high-level update. I did prepare because I thought you would probably ask me a question around it. So, I've recently undertaken a project evaluation report that looks at the success, if you like, of phases 1 and 2. So just to remind you all about what phases 1 and 2 were, they were calls relating to somebody's concern for welfare and walkouts, AWOLs from health facilities. So we're now transitioning into a stable operational phase, having achieved its primary objectives, the whole programme. So this period is allowing for fine-tuning, and we're resolving some of those outstanding minor issues whilst ensuring we're working towards long-term stability. So overall, phase 1 and 2 have been deemed a success, with all the deliverables functioning as intended and those stakeholder needs addressed, and the groundwork laid for future business cases, innovation and collaboration. And Nicola's already mentioned some of the work that we're doing with partners around the review of the police and health street triage. The phased approach, and I've mentioned this previously at previous updates, the planned phasing of the implementation along with partners has been really welcomed across all of the strategic partnership landscape, and it's really strengthened those working arrangements with our health colleagues, including obviously the 3 emergency services, healthcare providers and local authorities. And so the integrated care framework has been crucial to this, and it's raised the profile of other initiatives linked to the health and wellbeing of the communities of Staffordshire. So we are now in phases 3 and 4. There'll be a final project closure report due to land in about February once stabilisation is complete, and that will document lessons learned and outcomes realised, and it will also include a status update on that wider partner activity with a focus on phases 3, which is transportation of section 136 patients, and section 4, which is mental health activity and voluntary mental health. So only quite recently, and it was late in the day, but we were in a good position in terms of the Staffordshire approach. The guidance has come out from NHS England now around how to implement right care, right person. And I think we can safely say that our implementation with all our key partners, we're ahead of the game in terms of when you look at that overall recommendations. But there is always going to be work to do. I'm actually leaving the organisation at the end of March, but my job now is to make sure that the business as usual is handed over to the organisation, but particularly to encourage that ongoing partnership work with the likes of Nicola and colleagues across the partnership landscape.
Lisa, thank you very much for that. So, opportunity for questions, and I note what Karen said about the absolute scope of this, and perhaps in future we need to look at different bits of it in more of a bite-sized format if we're going to do any detailed analysis of it. But yeah, any questions, thoughts, comments from anyone? Or Richard, then?
Yeah, thanks, Chair. Just with a view to future reports, there's clearly a lot of stuff and a lot of good stuff going on. I'm not sure we're that clear about the difference it's making. So we've got a little bit of outcome data on suicides, which is quite heartening. Those rates have come down. But we haven't got a lot of other outcome data about, is mental health in Staffordshire getting better, worse, the same? So I wonder whether you could pull something together that approaches this from an outcomes perspective. Obviously, hearing the vignettes about the work going on is interesting, but we really should be focusing at this level, I think, on what we're actually achieving. So you mentioned some metrics. If we can get a suite of those metrics for each of the outcomes in the good mental health strategy, that would allow us, I think, to get a better handle on overall progress.
Yeah, I agree with that, because and the difficulty being is this is such a massive area that we were trying to keep slides short, which we failed miserably at because I think there was 20 of them. So I totally agree. I think where I would want a bit of clarity is which outcome measures we are looking at. Are we looking at the good mental health outcome measures that I know come to this board every quarter? Are we looking at the measures in the good mental health plan or strategy? Is it a combination of both? I just want to be clear on that, I suppose.
I suggest you sort of smush them together into one mental health dashboard somehow, which is relevant to all of the partners and interesting to us as well.
That's fine, because I think there'll be some measures that don't sit in either of those two that actually we'd probably want to include, if I'm honest. So that's good to get that clarity. Thank you.
Thank you. Thanks for the presentation. And I think it's a good suggestion from Richard to have some outcome data, because it's really difficult to see. Talk about some outcome data. We've celebrated the suicide rate going down, and that's fine. But the dashboard that came with this pack talks about a reduction in emergency admissions with a mental health diagnosis in adults, which is going the wrong way by a long way. What analysis have you done of that data? Because surely that's a subset of what we're talking about. Suicide is one far end, but actually emergency admission is en route to that. So we've not talked about that at all.
And I'm not sure I can comment on that because I'm from children's, and I'm not sure that I will have seen those data metrics that you're talking about either, if I'm honest, with not being a member of this board. I don't know.
So I think it's quite a complex issue. I mean, a lot of the coding that takes place is not as accurate as we would like in terms of how mental health is coded. So some of those presentations are around substance use, for example. So it's around sort of doing a deep dive into that, which we can look at. We do have a mental health dashboard that we review as part of the portfolio that does include those metrics. I think it is always challenging, particularly around certain seasonal periods with how urgent care flow is at times. But that is certainly something that I can look into and provide an explanation for.
Lisa, by all means.
This is just to, again, remind members of the board, we've talked about this before, there's a piece of work that is commencing in April next year, the partnership with the Keele University and the Staffordshire Centre for Data Analytics, which is looking at where police signpost users to services. That piece of work will look to see what those service users, if they did connect with who we're signposting them to, and equally what was the outcome of that. So I do need to link in with both trusts in relation to that work, just to make sure that we don't lose sight of that. And that will come back, I would suggest, to that board probably towards the end of next year.
Okay, thank you for that. So any other members of the board have any questions on that presentation or those presentations? Okay, no, and the recommendation was that we note it. Sorry, Claire, my apologies.
Just a really quick follow-on point from the conversation around reporting of outcomes. I'm just thinking it might be useful, given the conversations we've had at this board around the development of the new JSNA dashboard and the chapters within that, whether it might be worth us having a conversation to explore if we could do perhaps a JSNA chapter or something like that that aligns to each of the priority areas so that we've got it all in one place, because the ambition with that is that it's very much a partnership product and it brings together intelligence from across the system rather than it just being a county council product. So I think that could help take the JSNA further to be a much more useful tool, but also to give this a bit of sort of focus if that's something we can maybe explore.
Well, I think that's a very good suggestion and a good way forward. Okay, I think we've noted that. So thank you, colleagues, for your presentation. I will move on then to the next item on the agenda, item 3, which is Staffordshire and Stoke-on-Trent Adult Safeguarding Partnership Annual Report, which I think we're being joined by Adrian online and Ruth. Just come up here somewhere. Adrian, welcome to the Health and Wellbeing Board. Ruth is here to assist. And I understand you do have to leave shortly, and Ruth indicated she will take over. So over to yourself.
Right. Okay then. Thank you for having me here today. Just to remind members that the Safeguarding Adults Board covers adults with care and support needs and looks to protect them from abuse and neglect. So it's quite a tight remit. And our mission statement is to support adults with care and support needs, to make sure they're supported to make choices in how they live their lives in a place where they feel safe and secure and free from abuse. And we have a number of subgroups covering engagement and prevention, audit and assurance, and SARS. In terms of the Safeguarding Adult reviews, we've had 7 referrals of an incident that will cause a person to have died or to have suffered serious injury through concerns about the partnership working arrangements. And that generated 1 Safeguarding Adult review, and it also then led to 3 different single agency reviews. We've also published 3 reviews covering one called Frank and Elsie, which was a residential care situation where the couple were physically and sexually violent to residents and staff, and it covered issues of consent and identification of issues relating to their care and support and the risks that they presented. And as a result of that, we created products for around sexualized behavior in a residential care by vulnerable staff, and understanding of risk and multi-agency approach and placements involving care staff. Safeguarding Week also covered some things around mental capacity assessment and sexual safety, and that was attended by 104 attendees. We had the Andrew SAR, which related to an individual with multiple needs, covering mental health, drug and alcohol use, grief and self-neglect. And he was seen by he was seen on 307 occasions by 11 different agencies in the 18 months before he died, and that's created effective practice as a priority. And we've had the Gillian SAR, which will be published shortly. Well, it's published this year, but it isn't within the reporting period, and that covered self-neglect, professional curiosity, mental capacity, and multidisciplinary teams and awareness. When we look at the audits, the key themes for the board are referrals as an outcome, single agencies often left holding the risk, and that's where your multidisciplinary teams come in, lack of understanding of self-neglect, the protocols and risks associated with them, engaging with people, so they're the service users, as it were, and looking at making safeguarding personal and embedding that within staff, and the issue around consent and the advocacy that supports people around that, and the recording of decision making, the review of self-neglect pathways, which is already happening within this year's reporting period, and information sharing and update on progress. The board have received numerous presentations on items to cover reassurance and assurance, covering police public protection units, how the MASH arrangements are working. We've received 3 updates on that, and we've had presentations from the safeguarding information sharing group that covers both councils looking at the care sector. We've had presentations from prisons, looking at their safeguarding arrangements, which sit slightly outside of my board's remit. And we've had presentations on right care and right person, which has subsequently come in to being. And we've had 2 more presentations to reassure us on that. We've also had presentations on Pit Stop, which looked at a multi-agency approach to reviewing information about individuals. Looking at the strategic priorities, in terms of making safeguarding personal, well, we've carried on doing quality assurance audits around cases. We've got a new suite of training that looks together with Stoke at the new Joint Academy, and that includes care provider training. We've got supported by similar training in other agencies, including the foundation trusts, including issues regarding mental capacity assessment and DOLS. Well, we do have a backlog within DOLS. That's certainly improved significantly, and mental capacity assessment has now become a priority for the next 3 strategic years, 25-27. In terms of improving response to self-neglect, which are both linked to SARS, Andrew and Gillian, continues to be an emerging issue. So 70% of SARS nationally have got self-neglect parts to them, and they're becoming more complex and intersectional in their presentation. Pit Stop seeks to try and support this, as does membership of the board from citizen expert references and the voluntary and community sector. Transition between services continues to be an area of concern, and for Staffordshire we've got updated pathways, we've got better supervision and oversight, and that includes transition from young people on their journey to adulthood and accessible information for them. Looking at the seldom and hard elements of our communities, got multiple disadvantage, which links often through drugs and mental health to barriers of service access. We've got training in professional curiosity. We've got provider training in how to report concerns, and we've got supervisory increased oversight and weekly case conferences. We've got good quality assurance within the service providers. And I've already mentioned Pit Stop and recording quality has improved, and the access to identification of people with immigration status is better known, and therefore we can offer them and be reassured that they're getting more support. Looking at some of the numbers, in terms of concerns, Staffordshire have had 15,810 reports or referrals of concerns, and that's covers repeats of about 17%, and that's a pretty static number for the last 2 years. In terms of over 80-year-olds, those concern reports equate to 43% of that group. And obviously we're going to have a significant increase in our elderly population, so we would expect these concerns to raise. Types of concerns: neglect and omission is the highest, that's 30%, and that's down by 7%. Financial abuse is at 19%, psychological abuse is at 14%, and physical abuse at 12%. And where they originate from is their own home, 67%, which is down 3%, residential care at 13%, and nursing care, which is at 11%, and hospitals equate to 2% of that group. The main care type that Staffordshire are having to provide is for physical disability and also memory and cognitive issues. In terms of the section 42s, which is where inquiries have to be undertaken, it's a conversion rate of about 19% at 2,951. Performance on those is quite good. It's within the target, 75% are less than 90 days. Of those people, 63% responded to questions when asked, and of those groups, 73% felt that their needs were fully met, 18% that they were partially met, and 9% weren't met at all. In terms of the fully met, I think it's right to just mention that some of the question types, I think, have led to people actually answering that question in the negative, and I think actually the performance is higher. What I mean by that is that there are good examples where people have been asked the question what they want to happen, and they've included things that aren't relevant to safeguarding. And when those aren't met or can't be achieved, such as return of money in a fraud or somebody to be fired, then that has been counted as only partially or not met at all. So I actually think the performance is better than that. Areas of concern for the future for me are right care, right person. So the police are attending 900 incidents less a month. And so those will be channel shifted to other agencies, and we need to be aware of how those incidents are being dealt with, what the outcomes are, and that we're getting the appropriate referrals in place. In terms of the referrals, when you look at the population, it does appear proportionate, not the same issues that are visible within Stoke. Areas just to look at with are the Asian and Indian population. So we've got 0.8% Asian population, but only 0.3% within our Section 42 inquiries, and the Indian population at 1.1%, and they are appearing again at 0.3%. So areas just for us to look at, and one of our area priority number one is around that equality and finding those hidden groups and making sure that we've got the reach and the understanding within our wider communities. Looking wider, in terms of accessing training for safeguarding at 2.9%, the national average is 4.2%. Carers being consulted, got 25%. And our vacancy rate is average at 30%, at 10%, and our turnover is national average at 30%. In terms of care assessments, Staffordshire are doing 900 a month, the 70% within the 28 days and 80% within the 90-day period, and the average is 23 days. In terms of DOLs, they're up 16%. These are deprivation of liberty safeguards, 8,766. 4,000 of those are just churn within the system. They ended up without being authorised because they individually passed away, their needs expired, or they moved to a different location, which would require another authority. And in terms of financial assessments, targets at 90% reached within 45 days. And we've had 8,203 financial assessments. 5,810 of those were new, and there is a backlog of 400. So that is the data that links to the performance of Staffordshire in terms of care and support needs in the areas that we are concerned with. Overall, 68% of people are satisfied with their care and support needs, which I think is a quite a good figure, with areas to improve. With social care vacancies, as I've said, at 10%, but the staff with care certificates are 57%, which is good compared to other areas. And our advocacy use is at 50%. That's under the national average, but it's almost doubled. So there's been some great work in offering advocacy to members of the public with care and support needs who are being impacted by it. And overall, 73.3% following safeguarding intervention feel safe, and 85% felt that the safeguarding that Staffordshire had provided made them feel that way. So that's a whirlwind tour of the report. Obviously, you've got a 55-page document which goes into more individual detail of the reassurance that we've been provided and some of the issues. But overall, in terms of Staffordshire, I think the safeguarding is good. They're due for CQC inspection in the early part of next year. I don't think there's anything that contradicts the priorities of the Health and Wellbeing Board, and indeed I think actually we're supporting it.
Thank you, Adrian. Ruth, is there anything you want to add at all?
Not at this time, I don't think. I think it's just opening up to questions. It's obviously just context setting, just for people who didn't know, I suppose, with regards to the fact that the report that you will read will have been authored by our previous independent chair, John Wood. Obviously, those of you who will have known him, he left earlier on this year, and that's where Adrian's taken over. So just if you were thinking, gosh, it said John Wood, where is John Wood? He retired, and we have Adrian with us now.
That's lovely. Thank you for that clarification, Ruth. So, opportunity open for any questions from any members of the board at all? Yeah.
I want to have some clarity on ethnicity, because I know a lot of times in reports they put in Asia. Asian is a very broad term because it can vary. I know you've got a few different rows in the ethnicity side, but for example, where I am in the district, in the Lichfield side and surroundings, it's becoming more and more diverse. So is there more thorough in regards to, for example, like if it's Southeast Asian or if it's Chinese? Is there more clarity on those areas? Another question I'd like to ask is that for those, for example, if for those maybe who are, we could say immigrants or very, who are not prone to reports. I know there are numbers and there are groups where they support to report issues, but if they're not willing to, how do we tackle that? And one more question, if I fit in together, if I could, is there a breakdown in future reports of district and borough? Because I think that'd be really good for the district reps to take back to their side as well. Thank you.
You'll have to forgive me. I've got somebody at the door who's setting my dog off, but I don't know the answer to that in complete honesty. And that is an area that under priority 1 of the new priorities that we've set, we are going to actually drill down and understand better the different demographics, but also what relates to being felt as a community. So it takes it slightly wider than just either a country of origin or a specific demographic. So hopefully we will be able to give you a much better breakdown of the referrals, both geographic, demographic, but also how they then populate the Section 42s. So you're right to ask that question, and it's a question the board's asking of itself, and I would expect that we'll be able to give you more clarity next time round.
Just to add, I certainly know that we could break down the current data as it is by borough and district within. If that would be helpful, we can look to provide that. Obviously, if you want to provide what details you'd like alongside that, as in type of abuse, outcome, those sorts of things, whether you want it broken down by concern, maybe it's something that by all means do email me about, and we can see what we can get across for you. With regards to the breakdown of ethnicity, I think you're absolutely right. I think we do use broader terms in general in reporting, and I think it's absolutely, as Adrian has said, an area that we do need to look at and consider and make sure that we're making that more relevant for the communities in our area, so that people feel a connection with that. That may then help us to be able to hear more frequently as well and look at how we can better engage with our wider communities in a way that's more meaningful to them as well. Thank you.
Thank you, Adrian and Ruth, for a really thorough and clear summary of the annual Adult Safeguarding Partnership Board. Can you just confirm where else this report goes to, please?
Yeah, this report goes to the relevant lead chief executives of the statutory partners, that being both local authorities, police and ICB, but also some of the health leads. But it is also sent wider to partnership groups, shared with all the members of the board, and it is published publicly on the website. It's also mandated, as you'll be aware, to share with yourself, but it also goes to the 2 local authority scrutiny groups as well.
Thank you. So it gets a thorough airing at the scrutiny committee?
Yes, it does. I was at Stokes just last week.
Thank you.
Okay, and yes, Richard.
Not a question, Chair, but just to say thank you to Adrian for stepping into the role of Chair of the Adult Safeguarding Board and approaching it with such enthusiasm. And thank you, as always, to Ruth for your support you've been offering and for your leadership of our safeguarding operations. Thank you.
Okay, thank you very much. And the ask of the board was to note and question the annual report, which I think we've done. So, Ruth, Adrian, thank you very much. And then we'll move on to the next item on the agenda, which is item 4, which is the Staffordshire Safeguarding Children's Partnership Board, another annual report. Afternoon, Ian. Can you hear us?
I can hear you indeed. Can you hear me okay?
Yes, fine, thank you. So I've got Lynn, Vicky and Sharon here, obviously to support as well. So are you going to lead off, or is that you?
I indeed.
Lynn? Okay.
Okay. Afternoon, everybody. Do you want us to do some actual introductions first? Okay, so my name's Lynn Milligan. I'm the Business Manager for the Safeguarding Children Partnership.
Good afternoon, everybody. I'm Vicky Lee, Chief Superintendent for Staffordshire Police. I'm now the incoming Chair of the Staffordshire DSP, taking over from Ian.
Good afternoon, my name's Sharon Conlon. I'm the AD for All Age Safeguarding and the CYP Quality Lead at the ICB and a member of the partnership.
And good afternoon, everybody. My name's Ian Vinyl. I am the outgoing chair of the partnership and the current independent scrutineer for the Staffordshire Safeguarding Children's Partnership.
Thanks, Ian. And just to note, Bernie Brown's apologies for today's meeting. She did want to come, but sadly isn't very well. I just want to start by thanking everybody for inviting us to the meeting this afternoon and to present a summary of the activity and achievements across the partnership from April 23 to March 24. As I understand it, the link to the published annual report for the Safeguarding Partnership, which sits on the website, has been shared with you as part of this agenda item and along with the background report, and as such we'll assume that you are familiar with their content. With that said, therefore, the presentation that we'll run through this afternoon only intends to highlight the most pertinent areas, and I'll just kind of run through those with you to begin with. So we'll provide you with an update on the most recent position on the local partnership arrangements following publication of the statutory guidance, which was in December 2023, an overview of the main priority of the partnership, which was, for that reporting period, neglecting the under ones. A short summary will be provided of reviews where we seek to understand the learning following the death or serious harm to a child. An overview of child deaths, and it's great that we have the current chair of CDOP as well as the chair of the DSPs here today. Thank you, Vicky. And then also a brief synopsis of what's worked well under the arrangements, including areas presenting the most challenge moving forward. And then at the end, an opportunity for you to ask any questions to either myself, the DSPs, I refer to the DSPs as delegated safeguarding partners, or indeed Ian as the independent scrutineer. So Ian, do you want to talk to about the first slide? Have you got the...
Yeah, can you see that on the screen okay?
Do you want to share them, Ian? That's it.
Okay, is that, everyone see that okay? So just very briefly, I'll just update colleagues with regards to the arrangements in the partnership that's shifted under the new Working Together publication that, as Lynn has mentioned, was published in December 2023. When we reference the outgoing and incoming chair of the partnership, I've been the chair of the Safeguarding Partnership since May 2022. And in Working Together 2023, it was agreed that one of the lead partners should undertake that function. And obviously that's a decision that the police and the local authority and the Integrated Care Board have to make. and it was agreed that Vicky would pick up the chairing of the arrangements from myself for the next year. Obviously, that means that my role shifts and changes, so I become the independent scrutineer for the partnership. And that's a role that's designed to obviously to scrutinise the arrangements in Staffordshire and assure that they're working effectively. Obviously, as part of that arrangement, we've been looking at the arrangements in Staffordshire. We have transitioned, as it says there, to a partnership. Previously, it was a board. I think that emphasises the focus that there needs to be in relation to the partnership working to effectively safeguard children and young people in Staffordshire. That's the purpose of the change in terminology, which I think is quite helpful. Alongside that, the partnership has to publish a report and the arrangements for the partnership in December, later on December, I think the 20th of December, that has to be published, which effectively lays out for everyone the arrangements that are in place or going to be in place from December 2024. Included in that is the expectations and the new responsibilities and accountabilities placed on the Chief Constable of Staffordshire Police, the Chief Executives of the local authority and the ICB, who take a much more active strategic role in safeguarding arrangements moving forward, and those arrangements are delegated to Vicky and to Bernie and to Heather Johnston in the ICB. Obviously, as mentioned, refreshing the work of the partnership in terms of its vision, its priorities, and obviously the structure to support the arrangements. That work is currently ongoing. And importantly, we have to, and rightly so, engage colleagues from the early years sectors, from education and further education, as part of these new arrangements moving forward. And that will obviously be something that Vicky and colleagues will be doing actively in the new year. So I'll just hand over to Lynn now in terms of just updating colleagues with regards to the rest of the presentation.
Thanks, Ian. And we move on to the next slide, which kind of picks up on the area of neglect, which is, as I said at the beginning, is a priority for the partnership in the under ones. So this slide and the content of the annual report pretty much summarises the activity and outcomes achieved by the partners to improve our collective response to neglect. Lots of reviews locally, and these are child safeguarding practice reviews, indicate a lack of awareness of the cumulative effect of impact and particularly low-level impact neglect, and then how to respond in order to demonstrate the daily lived experience of children, particularly where those children are non-verbal because of either their age or stage of development. And this learning also mirrors the national picture that we found. This year in particular shows that there have been some positive outcomes for children, families and those working with children. And then you can see some of those on the slide here in particular and some of the work that's taken place to address that. As I understand it, in terms of the feature of neglect being a slight outlier in comparison to the national picture, the local authority have recognised that historically the category under which neglect is recorded on the system has at times been overused in Staffordshire, and in response have started to do some work to correctly recode the category, although recognising there's still a long way to go. There's a model that we use across Staffordshire called the Learning Hub, which allows us to do a deep dive into a particular theme. And what came out of that particular model was that we also found there was a misrecording of neglect on the system. So children experiencing exploitation, for example, were being coded as neglect rather than harm outside the home. So one of the key objectives was to ensure the partnership had a clear strategic approach in reducing the impact of parental risk factors by working with other strategic groups who play a key role in helping to deliver the desired outcomes. So aside from regularly meeting with strategic partners across the children and adult landscape, the partners worked with the Early Years Advisory Board, the Maternity Transformation Board and the Early Years Safeguarding Forum to influence delivery plans, increase the number of women who have access to community perinatal mental health services, and also to create an e-learning package called With or Without Words to improve the confidence of the workforce working with younger children who are non-verbal. Next slide, Ian, please. This slide gives you, hopefully offers you some insight into the activity between 2018, which is when the language from scoping panels, which are now called rapid reviews, and child safeguarding practice reviews, which were called serious case reviews. This slide gives you an overview really of the number of reviews that we've conducted across Staffordshire since that period of time. We are required to regularly report on the progress of our reviews, as well as the learning and how the learning translates into recommendations and actions by informing the National Child Safeguarding Practice Review Panel. Ofsted also keep an eye on the number of serious incident notifications that we make, and this is when a child either dies or suffers a significant injury and where neglect and or abuse is known or suspected. This slide and the following slide provide you with an overview on the number of serious incident notifications, rapid reviews and child safeguarding practice reviews, and also how we compare nationally, and refers also to a piece of work completed by the independent scrutineer, Ian. And then the second slide, if you want to move on to that slide, Ian. That gives you an overview of the recurring themes identified as part of both the serious incident notifications, so we learn, or we try to learn from each stage of the process, the rapid reviews, but also the child safeguarding practice reviews. And part of the review that Ian conducted does look at some of those recurring themes. So I'll just let you read, I won't read them all out, but they're all on there for you to have a look at. Okay, thank you, Ian, if you'd like to move on. Child deaths, again, the CDOP annual report, which is just being finalised, and we hope for it to be published in the new year. What we should have mentioned at the beginning is the timescales for reporting, both in the annual report and for the CDOP report, have slightly changed under the new arrangement, so we are required now to publish by September, which has meant that some of the parallel processes that we have around reporting are slightly out of kilter, but we do hope to publish the annual report, as I understand it, in the new year. But this gives you an overview of not just the kind of recurring modifiable factors as a result of those child deaths, but also as well some of the information around and including in the annual report around the average rate of deaths, and neonatal deaths are included in those. And we always say, don't we, we always continue to improve, and there could be more to do to improve, but I think there's a shift in thinking, particularly around the partnership, around rather doing more, let's do something different or better. So I don't know whether you want to add anything to that particular slide, Vicky.
I think when we go to in more detail the overarching comprehensive report around child death notifications, but essentially some of the primary things that the board is set up to do is to produce a report which articulates how we've responded from a child death review process to all of the deaths that happen in Staffordshire and Stoke-on-Trent. It's the only joint statutory board across the partnership as it stands at the moment, so it covers both areas. But we do intrusively break down the difference between Staffordshire and Stoke-on-Trent because we recognise that there's challenges in different areas. One of the key functions of that group is to identify what we call modifiable factors, which you'll see on the screen, which are essentially things that could have been changed that may have had an impact on that child's death. And some of the key ones which we'll see there, which is smoking, maternal obesity, drug and alcohol use, those are really frequent modifiable factors that are seen consistently across the country. So in Staffordshire particularly, our BMI does flex. We've had low BMIs at 16.2 of pregnant mothers, and also high BMIs between 30 and 40. It's a real challenge from a public health perspective. And the BMI challenges sit at 23% in all child death cases where modifiable factors were a feature across the country. And then just to touch on some of the emerging themes that we've seen during this reporting period from a child death perspective. So over Staffordshire and Stoke-on-Trent, there was 88 deaths within that reporting period, and 55 of those, which equates to 62.5%, were children under 1. So there is still really a strong focus in that infant mortality space. And when we mention infant mortality, we're talking about children up to the age of the first birthday. So within Staffordshire, there is an infant mortality group that again covers Staffordshire and Stoke-on-Trent, and they've got a really refreshed focus in relation to infant mortality. And only 2 weeks ago, they had a conference to devise what their plan's going to be to address some of these modifiable factors that have been pulled out through CDOP as health issues more broadly that needs to be working in that early preventative space even before ladies are pregnant.
some of the things that we can touch on and try and intervene and prevent in the future from a CDOT perspective more broadly is the increase that we've seen in suicide rates for children. So when I say children, I'm talking between the ages of 10 to 17. And while statistically it's very difficult to see whether or not there has been a statistically proven increase, however in Staffordshire there's been 4 cases. And in my mind, when you listen to those 4 cases at the panel, 4 cases is 4 cases too many. So it might not be statistically an outlier, but for a county the size of Staffordshire, we absolutely need to understand what's happening in the child mental health space. So we've commissioned a piece of work which will be reported back to you next year when we do the report to understand that in much more detail. And then finally, an increase in co-sleeping deaths with unsafe sleeping arrangements being the 5th most common modifiable factor, not only nationally but also here in Staffordshire. And when we say unsafe sleeping arrangements, we're thinking with cases such as children that are found collapsed on sofas, dangling off the end of beds through bed sheets, co-sleeping with multiple family members in a bed. So these are things that could have been prevented and stopped that child from dying. And then finally, deaths on the road. We have seen an increase in children, our teenagers, that have died on the road in a variety of different ways, whether as pedestrians, whether on motors, whether on push bikes, or whether actually in cars themselves as passengers, or on occasions drivers, young drivers on the road. So that's something that we're going to be working with the Community Safety Partnership on to address some of those environmental factors where we absolutely have got the opportunity to do so to minimise that risk from a child death perspective.
Okay, next slide please, Ian. So this is an area that is developing at pace in terms of our approach as a partnership to capturing the voice of children and those working with them. We know that many children across Staffordshire rely on adults working with them to build relationships, and we know that firsthand, particularly from those children that have been involved in our reviews, as a way of helping them to feel safe and also helping them to speak out when things become difficult for them. A conference that we held is an example of the first time that the partnership had held such an event, and was an example of how we sought to understand how best to talk to children so they'll listen, and how to listen so children can talk to us. We're due to run a similar event this year with a focus on specific cohorts of children who are classed as hard to reach, some of those children who don't have a voice or find it difficult to voice how they feel. And whilst we recognise and celebrate the achievements in this report across the partnership, we do not underestimate the amount of effort required to do this, and to do this well. And to continue to do this will take a shift in culture, behaviour and commitment to become child-centred, and that's no mean feat, as we know, but it can and has been achieved. The examples that are on the slide there in front of you include engagement with children who are in the secure estate, so at our Young Offenders Institution in the north of the county in Warrington. We've held many multi-agency practitioner engagement events. It's part and parcel of our review process is to talk to frontline staff, to understand what their lived experience is like, and then also how they work with children. And some of that has revealed some really good practice along the way. We conduct a variety of different platforms in which we can seek the views of practitioners, but also we've just started to develop more in line of how we do that with children, and you'll see more of that in the next year's annual report, but particularly around those children who are deemed as difficult to reach. And then moving on to slide 8, this is the final slide. So in summary, the key improvements include progress against inspections, so progress has been steady, but there is evidence that is the bigger picture that it is improving. There has been an improvement in the recruitment and retention of staff, particularly in children's social care. That did come out in some of our reviews, and obviously affects the kind of relationships that children have with frontline staff. We've certainly increased our understanding of the child's experience across the safeguarding system, and are doing more to understand that, particularly with those harder to reach groups. And one of the real successes is the implementation of the Learning Hub model. This enables us to have a clearer and a deeper line of sight to the frontline practice, but also in that understanding a child's lived experience. There are, as always, challenges that remain in working across partnerships, particularly with some of the complexities that brings about. So capacity comes up very often in the conversations that we have at strategic partnerships, but also at the front line as well. There is work that's still ongoing to strengthen performance and quality assurance, and also the really difficult one, which is evidencing impact and outcomes. And then also a big piece of work for this year is strengthening the connectivity that we have with other strategic partnerships, given that the work overlaps so much, and very often we all sit in similar meetings talking about similar things. So that's one thing that's high on the agenda of the new partnership arrangements moving forward. So I'll conclude really with any questions on either the annual report itself or anything in the presentation today. Thank you.
So thank you for all for that. So perhaps if I can start with the first sort of question, and perhaps to direct it to you, Vicky, because you spoke about it, and that's the CDOP report that will come to the next meeting. And will that give more detail about that infant mortality and the modifiable things that you spoke about?
It's got a number of different reporting slides in there. It breaks down infant mortality to enable you to have that analysis of the under ones, and then it talks more broadly from 0 to 17, broken down into the categories. There's also a focus in there in modifiable factors. It breaks down all the modifiable factors, shares how many of those deaths have got attributable modifiable factors, and where we sit in the local, regional, national picture as well.
That's great. Thank you very much for that. So any other questions by any of the presenters at all? Shall we start that side and we'll go that way around this time?
Yeah, so just picking up on the point about the road safety issues at that particular age group, and you mentioned you're going to work with CSPs to look at that. Just to put on the agenda as well, the SSRP, the Staffordshire Safer Roads Partnership as well, might be interested in hearing about that and seeing if there's anything that we can work together on to make that better.
Absolutely. So our CMPG colleagues, we have an operations group in Staffordshire where we look at every child that dies, regardless of their mode of death, and the CMPG colleagues, so that's the motorway colleagues and road policing colleagues now. We really get into the detail to understand what happened in relation to that particular hard case. We've tried to focus in. There is a percentage of those small, hard-to-reach groups, so your young drivers that have just passed the driving test that are out in the car with their mates, and then they tragically end up in a fatal situation. How do we reach that hard-to-reach group? Are they going to listen to advice that's given? So we're trying to think more creatively about how we can get into that group specifically. So our roads policing colleagues are working with partners to be able to understand that in a little bit more detail. And then some of the other tragedies that we've seen on the road are a little more difficult to be able to problem solve. But ones where there may have been some issues with lighting or infrastructure of the road or reoccurring incidents at that location, certainly with the support of colleagues, we'll be able to problem solve that to prevent future deaths. So we'll absolutely ensure you're linked in.
Gary, did I see you indicate? No, Phil, sorry.
Thanks, Chair. You probably know what I'm going to say. In terms of the partnership arrangements, obviously I'm keen to protect 15 years of good engagement from the voluntary sector. I know that that's a challenge in terms of how we fit into that being a sector as opposed to an organisation. Also aware that next week you're going to be publishing arrangements, so just keen to keep that on the agenda really to make sure that we protect some of the work that's outlined in the youth voice element of the report around co-production and support for the conference and other things that we're involved in on an ongoing basis, as well as ensuring the sector is sustained as a safe place for young people to engage with. 50,000 children and young people get involved through our membership every week, so it's a significant area that we would be keen to maintain safety in as much as possible. So yeah, I'm enjoying not attending as many meetings as I have done in the past, but obviously keen to remain connected and supportive.
Do you want to go? Okay. Thank you for that. I mean, I think it's really, really important to ensure that we keep you connected into the partnership arrangements. And next week, on the 18th of December, the strategic and tactical leads across the county, we're all coming together to really look at who do we need to engage with, because we recognise there might be some gaps in certain layers of the structure currently within Staffordshire, where we need to broaden that out to ensure that agencies and sectors such as yourself, particularly the voluntary sector, have got a voice and have got a seat at that table. Now, what we're hoping to do is streamline that so we get the right people at the right meetings at the right time, because we all recognise everyone's really, really busy. So we're trying to make sure that we do that in the most efficient way possible, but ensuring that you are connected in a consultative way as well. So once we've identified who we think would be useful to be at those, having spoke to all of our colleagues and mapped that out next week, we'll be able to share that more broadly for consultation. And if you feel that you would benefit from attendance at a particular meeting, I'd be really keen to hear that, and we certainly can discuss it. Is there anything you wanted to say?
No, I was just going to add on. Been a gap over more recent weeks, so therefore the new arrangements going forward absolutely are really keen that you know they need to embrace that part of the sector, because we can only work if we work as a partnership, and absolutely key to that partnership working going forward.
Leona? Yeah.
Hi, thank you. I was just going to mention about child death, because in previous reports I can see there's always been child death, but having increased is a very big concern. And I can see from, I was going to follow on from what Phil said about partnership, is that through chair, if able to break down again through district or borough where these are approximately, and if something that district and boroughs can assist with the local knowledge, or if that's something that can be sorted. I think that'd be really good if we could get some local knowledge in there, and how local councils, like the city, district borough councils can report, something like that.
I absolutely agree with you. I think more broadly around vulnerability, understanding it at district and borough level, I think is important. And I know that the local authority have commissioned a piece of work to do some problem profile or district geographic mapping to understand what it looks like in different districts across the county more broadly, so that they can have that view and lens on vulnerability. But to answer your question around child death specifically, the annual report does have a light touch in terms of breaking down the ethnicity and the communities that the children were in when they died. And I think it is a real area of focus that I'm really, really passionate about, but not just thinking about the cultural heritage, ethnicity, broaden it out in terms of intersectionality to understand what that looks like and where we can make the biggest difference. So as part of the child death work plan for 2025, there is a section on that with a promise and a commitment from all of the strategic partners that support that forum to reflect back and understand how we can do more to get that greater granular level of insight. And only last week at the last annual CDOT meeting of the year, we were discussing how we can engage with the voluntary sector, communities, community leads, to really start to share some of the messaging out into communities and also get their views. Now, it's really difficult when you've lost a child to go back and ask for a sense of how did it work for you, and we often only get feedback if it's been a negative experience, and we're very good in that acute space to address those particular issues. But how we need to be thoughtful about how we are engaging with certain communities to really understand, well, how did it feel for you? Is the service that you give, would it be one that I would be proud of, it would count to my families, and be really responsive to that? So to capture the voice of our communities in what is a really, really difficult subject, whilst hard to do, it's definitely our ambition to do so next year.
Thanks. I welcome the reports, but also the clear targets and strands of activity. I think that's helpful, particularly against where we came from. And I've seen a few of these now. Can I ask the same question as I asked the adults? Where else does this go to, please?
So again, the reports both go to the scrutiny committees, local authority scrutiny committees. It's also shared with the chief execs and the chief constable. It's a public-facing document as well, so it's published on the website, and it's also shared with the DFE. They are keen to see what we produce, as are the national panel. So the National Child Safeguarding Practice Review Panel specifically look at reviews and how we've adapted and moved forward based on the learning from reviews. So it sits more nationally as well as locally as well.
Gary?
Thank you, Chair. It's on the infant mortality again, I'm afraid. I think it's just interesting to see that those factors, those risk factors, were either articulated as, or I think could be readily interpreted, or perhaps misinterpreted, as being really only in relation to mums. So I just wondered if there was any assurance around the focus on the role of dads in those factors.
It certainly is, and the household more generally. So particularly with smoking as well, we do break that down between maternal smoking and then smoking in the household. And then we also look at the environmental factors, because we know that the neglect, the living conditions, the family makeup, domestic abuse. So all of those themes that come out of our reviews, we do
collate those, review those, and they are broken down, so we are able to report on them.
Okay, I can't see anyone else indicating, so thank you very much for that, and look forward to a CDOP annual report in due course. So thank you all for attending today, and Ian, thank you for you online.
Thank you.
Okay, we'll move on to the next item on the agenda, which is item 5, which is the ICB annual report. Paul, over to yourself then.
Thank you, Chair. Is anyone in control of the slides? Just right.
Yeah, the slides were certainly in the pack, Paul. So perhaps we don't need to go into them in great detail because they were there for everyone to have a look at.
That was going to be my first question, just to check. Can I assume that it's taken as read, which will help me skim through this a bit more quickly? So, in terms of the what is an ICB, I'll skim over that. We know what an ICB is by now, hopefully. So our annual report 23-24 was the first full year report the ICB had done. We'd done one in the previous year, but because we were established partway through the reporting the financial year, we did a sort of a lighter version of the annual report. So last year's that's being discussed today was the first full version. So the annual report itself as a document is a heavily prescribed, heavily dictated sort of content from the Department of Health and Social Care and NHS England. So we have a sort of fairly sort of tight framework to work within. So it covers a whole large number of areas that are mandatory disclosures. So it covers a whole range of things which are of interest to the Health and Wellbeing boards in Staffordshire. It talks about the sort of the key risks, the key challenges, the key successes the ICB has achieved in the financial year, what it did with its money that it gets from the centre, what its priorities were, what it managed to deliver, etc. So whilst the report itself is compliant with the template and the guidance, which gets on for a couple of 100 pages in length, we are always of a mind that it can be done better. It might not necessarily always be done differently, because as I say, the contents are quite heavily prescribed, but we have a degree of latitude within each of the mandatory sections to sort of engage and work and to produce a better quality report. So hopefully by bringing it here today and focusing on the last couple of slides which are in the presentation, which I'll come on to in a second, we can hopefully get to an improved version for the 24-25 year with your help and support. So that's the key purpose of bringing it today. So rather than go through the annual report page by page by page and say what it covers, the presentation gives an overview of what are the mandatory contents. So the key three areas are the performance report, the accountability report, and the annual accounts themselves. They're prescribed by HM Treasury and Director of Health and Social Care, etc., etc. So we have to include those, and what goes in those has to cover certain areas. So the performance report is the section. I'll just move on to that. The performance report is the main bit of interest to the Health and Wellbeing Board, in terms of that's the area where we make some mandatory disclosures about what have we done about working in partnership with yourselves, with the Integrated Care Partnership. What have we done in terms of discharging our statutory duties around improving population health, reducing inequalities, working with the Health and Wellbeing Boards to deliver the joint health and wellbeing strategies and the priorities of those, how well our joint forward plan, as it's called for the NHS, has a degree of congruence with the integrated care strategy, the health and wellbeing strategies. So it gives an overview of how we've done that. It's quite process orientated at the moment, and there are some opportunities, we believe, to work with you to look at what are the mandatory disclosures, but can we do it in a way that's better in the time we've been given, which is not lengthy. So it will come out in January some point, the new template and the new guidance. And then by the end of April, we have to have done a full, first version draft to submit to NHS England for their scrutiny, and it goes off to the external auditors to be audited, etc., etc. So we have a really small, narrow window of opportunity, but that doesn't mean that can get in the way of working on the mandatory areas that we need to work on better, and to make it more meaningful and more triangulated with all of the wider work that is encompassed in all of those strategies and all of those documents. So that's the angle we'd like to sort of explore with you today, and also in the coming months. So that's the I'll just skim over the rest of it. So the highlights is that it is what it is. The important bit, as said, is the looking forward. So we would like to engage as early as we can, once we know what it is we're required to do, which, as I said, will be in January time. So we have 3 months to work together to do the mandatory sections on health inequalities and discharging statutory duties around improving population health. So there are areas, as I said, around the local health and wellbeing strategy that we have to have regard to, and it has to come to yourselves in March, ideally, to be signed off, or that section that we work together on to be signed off. So we're looking at probably January, February time to sort of get together and, talk about how well have we discharged the duties around the health and wellbeing strategy, etc., etc. So how we do that, I believe, can be done better next year. It's going to be your guidance, your insights, your help, which will help us get to better. So that's really sort of like the offer on the table, really, is to how can we make it more meaningful, less sort of process, more kind of, are we doing what we're supposed to do? Is it consistent with what you are expecting of us in terms of engagement with the Health and Wellbeing Board? And are there any areas that we could take forward together better in the following year? So that's really the kind of the ask of today, is how do we work together to do that? So that's the bit where it's sort of open to ideas and suggestions, please.
Yeah, well, certainly I would certainly, from my personal perspective, really welcome that approach to work more collaboratively to be able to achieve that. But be interested to understand colleagues around the table's view. Richard?
Yeah, no, I think that'd be really interesting to explore. The report itself is a combination of relatively boring stuff like committees, and then really interesting stuff like where the money goes and what activity and outcomes have been generated as a consequence. So drawing out the kind of Staffordshire narrative from that, I think would be really interesting to explore how we might do that.
Elizabeth, and welcome to the Health and Wellbeing Board.
Thank you very much, Chair. Pleasure to be here. Nice to be here at the first meeting since I've joined the ICB in September, and looking forward to joining you, obviously, throughout next year. I just thought I might make a comment and make a connection, which exists in my mind anyway, between what Paul is sharing as an opportunity and the point that's raised, I think, in the later agenda item about a review. I think one of the objectives of the review is to clarify, or proposed review, which I know we'll come on to, is to clarify the unique role of the Health and Wellbeing Board within the integrated care system. And I think the combination of that work and this opportunity to consider how do we reflect and report on the work we've done through the ICB as part of the Health and Wellbeing Board, and in this space, at least in my mind, there's a connection there. So it feels like clarifying that, the purpose, and then being able to report and respond to that could be a really useful thing that we do together. So I think those two things feel like they fit together well in terms of the items we're going to talk about today.
Any other comments? Yeah, Claire, I was just wondering, and Miriam, whether it would be worth sort of doing the board review just at this moment in time, and we'll come back to Elizabeth's other item agenda and combining the two, as we seem to be talking about one and the same thing here. If, Paul, you're okay with that, I want to sort of take your item over. So, yeah, Claire?
Thank you. Yeah, that makes sense. My comment was to bring the two together, really. Would really welcome that piece of work and that conversation. I think things are improving between individual organisations and across the system in terms of that integration, but I think there's still a bit of a disconnect, and it feels a bit disjointed still in terms of some of the work we're doing around health inequalities. So we've been talking and sort of doing work in the background around a health inequality strategy for a long time now, but we don't still seem to have got it over the line. So how do we sort of get there? And I think there's lots of really good stuff happening with other partnerships like the Improving Population Health Board that the ICB leads, but I'm not necessarily seeing integration with the Health and Wellbeing Board and particularly the Health and Wellbeing Strategy. So how do we sort of pay heed to the priorities within that strategy and sort of make sure that's weaved through those programmes of work? I don't see that necessarily particularly. So I think that could be really positive, and it does, as you say, lead nicely into the item around the review of the board, which in a similar vein, I think, because of the evolution of the integrated health and care system and the world within which we're operating over the last few years, although we review the terms of reference every year, it feels timely now to probably do something a bit more substantial in terms of looking at the board, its role within the system, where this sort of statutory partnership sits and its kind of key functions, I guess, alongside all those many other partnerships that exist. I know we've had conversations here in the past, for example, about whether infant mortality should be a priority for this board when it's also a priority for so many other partnerships. And sometimes when things are the responsibility of everybody, they sort of become the responsibility of nobody. So how do we give this group, this board, some real sort of gravitas, some teeth, and a sort of a clear sense of purpose and focus, and equally get feedback from members about what they would like it to be, whether it's meeting their needs in terms of their individual organisations, whether it's doing what they need it to do across the system. So just really giving opportunity for people to voice those opinions and to feedback into that review. So the proposal is that between now and March, we, the Royal We, mainly Miriam, lead some interviews with members and people who are sort of attendees, regular attendees at this board for various reasons, so perhaps priority theme leads as well, and other people that you might recommend, so that can be as broad as we want it to be, I guess. And also look at examples of good practice from elsewhere in terms of how other health and wellbeing boards operate. We do obviously have a slightly unusual position here where we have the Stoke-on-Trent Health and Wellbeing Board as well, which means we can't always do things in one go, which makes things a bit more complicated, but I think we can work through that. So the proposal is very high level, really just to seek support from the board to do that piece of work and then come back with some recommendations next year.
Miriam, you anything to add on that or not? No, okay. You'll just do all the work behind the scenes. So, open to colleagues whether you've any comment on Paul's presentation about the ICB and your report process and those priorities, and also what Claire's just spoken about how we go forward and try and develop the health and wellbeing board, because I think interesting points that have been picked up, you know, that and I think it was picked up a little bit, wasn't it, by the last two presentations and the questions that Jeremy asked about where else do you present these things to, you know, and quite often we go to things, don't we, and we've listened to the same presentation in a slightly different format at numerous other places. And I see Lisa smiling at me and I'm sure she's done it with Right Care, right Person on many occasions. So that I think the more that we can bring things together and slimline the process and whatever, so we achieve those outcomes and we know where we're going, all the better. So any comments from any other colleagues on that?
I would welcome that suggestion. It's interesting how it's called a joint strategic needs assessment, and different partners around the table have a different understanding of what those needs and priorities are. And I think it would help all partners if we actually aligned around the ones that we commonly want to focus in on and then deliver against. And so I think having greater clarity can only be a benefit to that, and hopefully greater delivery for our residents. Will the review, however, take into account input from the local government association, the LGA. They specifically do work on health and wellbeing boards and have got quite a lot of insight from across the country in terms of those that really do work well as a partnership board.
Yeah, I think it can do. So we have done that in the past. I know John had previously engaged with the LGA on a past review, so that was certainly a useful exercise, so I don't see why we couldn't do that again.
On the basis it doesn't delay delivery of the March timeline.
Leona?
Really quick one. I really welcome that review, actually, and especially from the district and borough. I think they have lots of comments, especially most of the councils, they have a health group as well. So I think loads of task groups. For example, like Lichfield, we've got a task group, and feeding into that would be brilliant. Again, if, as I emphasised before in the meetings, of breakdowns of district activities and also ethnicities and communities, that'd be really helpful because we can help with the engagement as well. Thank you.
Okay, so that's good, and thank you for those comments. And when I spoke to Miriam earlier this week about my sort of response to that, the role of district and boroughs we raised and we spoke about, which I think is really important for you to be able to share the views of all the districts and boroughs and be able to take back information from the Health and Wellbeing Board to all districts and boroughs and not just the one that the individual members represent. Okay, so two things from that. We've done two items in one in effect, and that was to note the Integrated Care Board's annual report and those timescales, what Paul presented, and then also the other item that Claire's now spoken about, and that's the review of the Health and Wellbeing Board going forward, and to note those. So unless anyone else got any other comments on that, we'll move back to the item that was in between those two, which was the Better Care Fund review update from Elizabeth.
Thank you, Chair. So I'm able to be really brief on this because noting it will come back with a sort of formal report at the next meeting led by a colleague. Of course, I'll be here, but my colleague will lead the report then. So this is really just a brief verbal update on the Better Care Fund review process that's ongoing. So in July of this year, the integrated care system, with the approval, because the Health and Wellbeing Board is the governing body, with the approval of the Health and Wellbeing Boards, commenced a review of the Better Care Funds. That's being jointly delivered between the ICB and the local authority, two local authority commissioning teams in both Staffordshire and Stoke-on-Trent, and also involving a range of our partners that provide services under the Better Care Fund. We set about a line-by-line review, because every year we set a plan for the use of the Better Care Fund, so it's agreed in terms of, a number of services and schemes that we agree to invest in. But what we realised is that there was quite an opportunity for us to take a look at what we were currently investing in. So that review is ongoing. The review is really taking, it requires, I guess, the collective intelligence, resources and leadership from our teams, and that's the approach that we're taking, and a number of principles for the review have been agreed and they're being worked through. There's a standard kind of process we're asking for teams to take a look at in terms of each of the lines of the Better Care Fund review, and the idea is that we'll do this initial review to understand what do we know about the investments that we have been making, what are the outcomes we're getting, and how much about those outcomes do we know, because it will be variable. We've seen, as we've heard today, our ability to have some of the outcomes data and present it clearly is variable, and it's a task that we're working on together. But that is part of what the review is intended to do. So the idea being that we take a look at the current investments and work out where we might need to see some change in the future. I suspect the review will get us to a common start line almost in terms of increased levels of understanding about value, and I think there will be ongoing requirement for more of a strategic look at how we use the Better Care Fund as partners to get the best outcomes, services and the best value for our population. So I guess I'm here to say we are midway through this first part of a review. I think it's already telling us this is a longer term process for us to be in as partners looking to the future, but we will report back at the next Health and Wellbeing Board with a formal report as to the kind of outcome of this initial stage, and as I say, I'll be accompanied by colleagues to do that at the next meeting. Thank you.
Elizabeth, thank you for that update. Any questions, comments on that? Okay, if we haven't, thank you very much for and we move on to the last item, which is the forward plan. And to yourself, Miriam.
Hello. So we do have a number of items for the March meeting, so we might need to review that ahead of that meeting. So at the moment we've got the Healthy Ageing Priority Progress Update, which is linked to the Health and Wellbeing Board strategy, the Staffordshire and Stoke-on-Trent Alcohol Strategy, the Integrated Care System and Joint Local Health and Wellbeing Board strategy, Public Engagement, which is a Health Watch update, Disability and Neurodiversity Partnership Board update, Child Death Overview Annual Report, Better Care Fund Review, the conclusion from the Health and Wellbeing Board review, and the Right Care, Right Plan update. So there's a lot.
Okay, I think between now and then we might have to look and see exactly where we're going to go with that, depending on what's ready and what comes out of the review. I think the review of ourselves going forward, I think that's a particularly important thing, and the CDOT report has been put back from this meeting to the next meeting. But I'm sure we can review that between now and then. So, ladies and gentlemen, thank you very much for your attendance this afternoon. And I suppose it only leaves me one thing: wish everyone a very Merry Christmas and a Happy New Year. And I'll see you all on the 6th of March.